slow. We shall go on to our next speaker, Dr. Ratni David, who again is a senior consultant glaucoma services at Shankar Nethralaya. And she's going to be talking on another very important topic, managing tube exposure smile pearls. On to you, Dr. Ratni. No, I'm sorry. Her topic is needle revision and surgical revision of failing blebs. So very sorry. What can we hope to achieve?
Thank you, ma'am. I'd like to thank ARC for the opportunity. Needle revision and surgical revision of failing blebs, what we hope to achieve. Trabeculectomy is still the most preferred anti-glaucoma surgery. Numerous modifications have been tried over the ages to achieve the ideal bleb. A functioning bleb must be low, diffuse, moderately thin-walled, relatively avascular with presence of microcysts. Post-operative management of the filtering bleb is just as vital as performing the trabeculectomy itself. Failure of filtering surgery occurs at various levels, namely at the level of the internal ostium or at the scleral flap level and at the subconjunctival level. It is important to look out for early signs of bleb failure, namely such as elevation of intraocular pressure, signs of vascularization, hyperemia, and flat bleb with the disappearance of the microcysts. Steroids go a long way in wound modulation, and they help to act in the early phase of the inflammatory cascade. An intense topical steroid regimen is usually advocated to reduce inflammation and hence scarring. Injecting antifibrotics like 5-FU usually at the appearance of vascularization and also helps to inhibit fibroblastic proliferation. Short video of injecting
5-fluorouracil. A cotton bud soaked in tropical proparcaine is kept on the intended site of injection well away from the bleb for a minute, and then the injection 5-fluorouracil in a dose of 5 milligrams in 0.1 ml is injected by creating a long needle tract in order to avoid spillover of the drug from the tract. The cotton bud is again placed at the site of injection to alleviate pain, and it also helps in diffusing the drug.
In case of a flat bleb with raised intraocular pressure in the early postoperative period, the decision to manipulate the scleral flap sutures is usually based on the bleb morphology as well as the intraocular pressure. Suture removal usually works best when done within 3 weeks postoperatively. The techniques of scleral flap manipulation include bleb massage to facilitate the aqueous outflow through the scleral flap edges, removal of releasable sutures, argon laser suture lysis, and bleb needling. Bleb needling is considered a less invasive and a useful alternative in the setting of a failing trabeculectomy, especially when suture lysis or releasable suture removal does not have much of an effect. The aim of needling is to release the scarring and fibrosis at the subconjunctival and the episcleral interface using a needle and increasing the subtenon's aqueous lakes, thereby restoring the bleb function. It's noteworthy to avoid use of anti-glaucoma agents in the early post-op as it further reduces filtration of aqueous and thereby increases contact between the conjunctiva and episclera, promoting fibrosis and potentiating scarring. Some of the prerequisites before needling include a careful slit lamp examination of the bleb, look for encystment or whether it is a flat bleb with conjunctiva adherent to the sclera or a small thin cystic bleb. Conioscopy is mandatory to confirm the patency of the ostium and to rule out the presence of any iris or vitreous plugging the ostium. The procedure has maximum benefit when performed within the first 3 months of surgery. The success is reported to be much better in elevated encysted blebs rather than flat blebs, especially when performed in the first 3 months. Needling can be performed as an office procedure in the slit lamp under sterile precautions or in the operating theater, where it can be done in a more controlled fashion. Sometimes more than one revision may be required. The use of adjuvants like antimetabolites have increased the success of the procedure. Mitomycin C is definitely more superior than 5-fluorouracil when it comes to needling, and MMC needle blebs need fewer revisions. The methods of application described are numerous. Some of them include subconjunctival MMC injection, transconjunctival MMC soap sponges placed over the intact sclera, and injecting 5-FU subconjunctively at the end of needling. The choice of the cutting device varies from surgeon to surgeon. A 30-gauge needle may be too thin and flexible to break the adhesions. A 26 or 27-gauge needle may be ideal. A 23-gauge MBR blade may also be used in thick-walled blebs. The short video on needling.
Bleb needling is done with the aim of breaking the fibrotic adhesions at the subconjunctival and episcleral level, and thereby re-establishing the outflow from the anterior chamber to the subconjunctival space. Use of antifibrotics during needling improves the success of the procedure. In this video, 0.1 ml of mitomycin C in the dose of 0.4 milligram per ml is injected posterior to the bleb, and the drug is dispersed into the bleb with the help of a cotton bud 20 minutes prior to the procedure. Then a 27 gauge needle is bent and introduced into the subconjunctival space about 5 millimeters away from the bleb. Multiple punctures and sweeping movements are made with the needle in order to break the fibrotic adhesions. One can observe the bleb forming, and then a paracentesis is created, and on hydration, a diffuse bleb is formed.
Sometimes it may be required to revise the internal ostium also by passing the a spatula through the anterior chamber into the ostium. It can needling can also be performed at the slit lamp, where a 27 gauge needle is bent and it's passed subconjunctivally advanced towards the scleral flap, and by gentle sweeping motions, the episcleral adhesions are broken, and one can see the bleb reforming. Sometimes thereafter, it has to be augmented by injection 5-FUs and teaching the patient to do a bleb massage. This is how encapsulated it looked before needling, and after needling, you can see a low diffuse bleb. Needling with 5-fluorouracil is an effective intervention in the short and medium term, but long-term results show that it needs additional intervention. Needling with MMC is effective for controlling IOP even several years after the original trabeculectomy. The success criteria in various studies have different definitions, and repeat needlings have also been.
You have 1 minute remaining, ma'am.
Okay, sir. Repeat needling has also been included within the success definitions, and the concentrations of antimetabolites also vary from study to study, making comparisons difficult. A systematic review and meta-analysis done by Shen et al. They reported that the MMC group had a success of 48% and complete success, and a qualified success of 70%. And the 5-FU group, they had a complete success of 44% and a qualified success of 70%. The risk factors for failure include duration more than 3 months, younger age, phakics, prior multiple surgeries, previous multiple attempts at needling, high pre-needling IOP, and high post-needling IOP of more than 10 millimeters of mercury. The complications usually reported are intra-bleb hemorrhage, which is the commonest, bleb leaks, overfiltering, shallow anterior chamber, choroidals, and blebitis. Usually, bleb leaks and overfiltering are usually self-limiting. In some cases, conservative management like BCL application, aqueous suppressant, and reducing steroids may be needed. In case of persistent hypotony, one may need to resort to surgical interventions like AC reformation, resuturing, and choroidal drainage. So the conclusion is bleb needling is a safe and effective method and can be tried in failing filtering surgery. It is prudent to try needling before resorting to any medical or further aggressive surgical interventions. Thank you for the opportunity.
That was a wonderful talk. I'm just going to take 2 rapid questions with you. How early or how late would you do a needling? And what is the endpoint of injecting 5-FU? Like how many 5-FUs would you give? Dr. Ratni?
Yes, usually we needle even early in the early postoperative period, even as early as 2-3 weeks if we see any encystment and or an elevated IOP. Needling can be done even up to 2 years, but however the success definitely decreases with time. And 5-FUs usually up to 5 to 6, not more than that. It usually doesn't really have much of an effect beyond that number.
Murli, you have any question to ask before we go on to our next speaker?
Yeah, I have one question which I forgot to ask the panel. What is your policy in treating aphakic glaucoma? I mean, sometimes you get patients who have had a complicated cataract surgery outside, have an iris clip IOL in place, or some such, or a large PCR. So, and if they needed a trab sometime in a trab or some kind of a glaucoma surgical procedure in future, what would be the choice of the panel?
Only I can just, I really want to say something that
a very excellent talk about the needling, very nice videos. But please remember that even years and years later, you can do it successfully.
Yes.
So there's really no time gap. As a matter of fact, I had a patient who had done 10 years back and they wanted to go out. So Robert Rich did it for them and then put 5FU over there. 10 years later, it is now functioning beautifully for 5 more years. So there's really no time limit for that, for doing a
If the
needling.
internal ostium is clogged by iris or so, I mean, is it worthwhile trying to sweep the iris out and do a needling? Usually the bleb would be flat in these cases.
Yes, it makes sense. We have to release the ostium and then only go on to combine it with needling, because by the time there's subconjunctival and subscleral fibrosis also. Yes. And your other question, Murli, you had asked?
Yeah, was about managing glaucoma in
Aphakic glaucoma. Anyone, Dr. Krishnadas, Dr. Shushmita, you have anything to add on that?
My choice for aphakic glaucomas would be a tube, one of the few for primary tube. I usually wouldn't do a trab in that, they somehow fail. And just one small thing about needling, I always do a gonioscopy before.
Yes.
And it tells me whether or not the subtenons might, because if the fish mouthing is there of the internal ostium, it tells me that it's probably subtenons. But if it's like a slit, that's probably that it's closed, and just a subtenons may not work in that, just a small tip.
Yes, a very
So
relevant.
this aphakic glaucoma, does it include the iris claw IOLs and other complicated cataract surgeries like SF IOLs, which are done by, I mean, would that also fall under the ambit of aphakic glaucoma? If they develop a glaucoma, you would still consider a tube?
Yeah. Once cataract surgery is done, I would usually, somehow the trabs don't seem to work so well. Once cataract surgery has glaucoma with them. So I do a tube, I mean, that's my personal preference.
Dr. Krishnadas?
I agree with Sushmita. For aphakic eyes, trabs do not work, and complications are also higher, like choroidal effusions, hemorrhage. Such drastic complications are also higher with trabeculectomies in aphakia. The only exemption probably would be a nicely placed PCIOL, uneven fill PCIOL implantation without complications, with untouched conjunctiva, clear corneal phaco done earlier. These eyes trabs work very well. In fact, they work better than aphakic eyes I have seen. But aphakic eyes, whether it iris claw or SF-IOL, it's preferable to probably do.
Yes. Thank you very much.